A quiet crisis is unfolding at the intersection of two relentless trends: global population aging and rising obesity rates. Together, these forces are converging to create a public health emergency with profound consequences: an escalating burden of cancer in older adults. This is not a marginal issue. It is a demographic time bomb, and we are vastly underestimating its reach and impact. The combination of aging and obesity does not just additively increase cancer risk, it amplifies it. And the systems we rely on to detect, treat, and support patients are not prepared. Age is the strongest non-modifiable risk factor for cancer. As people age, the cumulative effects of DNA damage, reduced immune surveillance, and changes in tissue microenvironments make the body more vulnerable to malignant transformation. But obesity adds a dangerous accelerant. It fuels chronic inflammation, alters hormone levels, and impairs immune function, biological changes that overlap with and intensify the vulnerabilities of aging. This synergistic effect is not hypothetical. It's showing up in cancer registries and hospital wards around the world. Cancers that are already more common in older adults, like breast, colorectal, pancreatic, liver, endometrial, and kidney cancer, are now being seen with greater frequency in obese seniors. These cancers are not only more likely to develop, but they also tend to behave more aggressively in patients with obesity. Tumors are harder to detect, treatments are more complicated, and outcomes are often worse. Older adults already face higher cancer mortality, in part because many are diagnosed at later stages. Obesity exacerbates this diagnostic lag. Imaging technologies may be less effective in detecting tumors in obese patients, while symptoms like fatigue, discomfort, or gastrointestinal distress are more easily dismissed or misattributed to aging or existing chronic conditions. This masking effect leads to delayed interventions when treatments are less successful and more physically taxing. Furthermore, treatment itself becomes more dangerous. Obese older adults are at increased risk for surgical complications, chemotherapy toxicity, and radiation inaccuracies. Yet despite this, they are often underrepresented in clinical trials. As a result, there is a lack of tailored guidance for oncologists treating this increasingly common patient profile, the elderly person with obesity and cancer. Instead, clinicians are left to extrapolate from studies that exclude or underreport data on these high-risk groups. And then there is the hidden toll on independence, on quality of life, and on mental health. Cancer treatment in the elderly is already physically and emotionally draining. When compounded by obesity, patients may be less mobile, more isolated, and more prone to depression. They may require longer hospital stays and more intensive rehabilitation. Many will never fully recover functional capacity, leading to loss of autonomy and a higher likelihood of institutionalization. This reality is especially urgent given the global demographic shift underway. By 2050, the number of people over 60 will nearly double worldwide. At the same time, obesity rates in adults over 65 are rising sharply. In the United States, more than 40% of older adults are now classified as obese. Similar trends are emerging across Europe, Asia, and Latin America as processed diets and sedentary lifestyles become entrenched even among the elderly. Public health messaging and policy have not caught up with this dual threat. Obesity prevention efforts often target the young, while cancer awareness campaigns typically focus on early detection in midlife. There is little focus on how obesity management can and should be a core part of healthy aging strategies. Worse, many healthcare systems still treat weight gain in older adults as benign or inevitable. This misconception is not only outdated, it's dangerous. There is also a dangerous equity gap. In many low and middle-income countries, older adults are increasingly exposed to obesogenic environments, urban food deserts, poor walkability, cheap ultra-processed foods, without access to preventive care or cancer screening. These individuals are at heightened risk of late diagnosis, undertreatment, and avoidable death. Aging and obesity, when combined, disproportionately impact the poor, the rural, and the socially marginalized. The response must be urgent and multifaceted. Cancer risk reduction in older adults must include weight management as a core component. This doesn't mean rigid calorie counting or extreme diets for seniors. It means creating systems that promote lifelong mobility, access to whole foods, community engagement, and medical care that takes weight seriously as a cancer risk factor, even late in life. It means clinical trials must begin including older and obese patients in meaningful numbers. It means caregivers and providers must be trained to recognize the compounding risks and not normalize obesity simply because a person is aging. Above all, it means changing the narrative. Aging is not destiny, and neither is cancer. Obesity is not harmless in the elderly. It is a driver of disease and death. The growing tide of cancer among older adults with obesity is not an inevitable consequence of modern life. It is the result of decades of neglect, misinformation, and policy inertia. If we fail to act now, we will soon find ourselves overwhelmed, not only by cancer cases, but by a generation of older adults suffering preventable illness, avoidable suffering, and premature death. This double burden is one of the clearest warning signs of our time. It demands bold, immediate, and sustained attention before the cost becomes irreversible.